Thank you, Seema. Thank you all for being here. I was hoping to do this in person, but given our current context, we will make do. So today I really want to talk about embedding data collection in public health. And by that, I'll explain a little bit why there's so many words in that title. It's a bit long as we go through. But I think this is really relevant to the work all of you do. And I also feel like you probably have a lot of experience in the space that you can add to this. So I am not the foremost authority. I have some experience with sharing that. And so I would love to get your input along the way. A few data points about me. So I had a really lengthy introduction. I'm going to fly through this part. But this is my personal dashboard right now. So I don't know if anybody's familiar with those little islands in the far left, but I grew up in Hawaii, just very far from everything. I actually grew up on the island of Maui, which is the second biggest one there. I've had over 12 years of experience now in this space. I'm actually not that old. I started doing this work while I was an undergraduate in impact measurement and collecting data on paper-based forms, a lot of mail-in surveys. And so I've kind of seen this develop over time, which is fascinating. On the third one there, you've got this nice little chart. That is actually from the work I did in Mumbai with the Foundation for Mother and Child Health. So I was the CEO there briefly for a transitional period and looking really at how in public health we can use data better. And this is just a little glimpse of looking at attendance rates for education programs compared with birth weights of those mothers. So I'll talk about that more later, but that's what really inspired this interest in public health and data in public health. I've now worked with over 60 individual organizations globally on helping define both their strategy for using data, but also how to use technology more effectively. That middle one, I don't know if anybody's familiar with that, but that's the Bangalore metro system. So I'm currently based in the middle of that, in the middle of Bangalore. I'm enjoying life here. It's my second time living in India. And the one on the far right, fun fact about me, that's my current average run distance in miles. So in kilometers, I think that's about 8.5 kilometers, but 5.2 miles. So last year I did my first ultra marathon, and I love using data time, my fun time, also for a little bit of a geeky note there to end on. Okay, let's get more into the matter at hand. So why does embedding data matter? Let's talk about that, and then let's look at what does it look like, both theoretically, what are we talking about, but also in practice, a couple of case studies. And then I think for everybody here, this will be really interesting to discuss, as well as how can we apply this. So in NORA, but also beyond in the sector itself, what does this mean? How can we use it? So that's what we're heading into. I'm going to try to keep it a little bit shorter so we have more time for discussion. But again, interrupt me if you have questions along the way. Okay. So when I was putting this together, it was actually before last week became a little bit more minds. And I don't think we can talk about data in public health today without talking about where we are sitting in time and space in the context of a pandemic. And for me, that's also very interesting because you see having proper data in real time when you think about something like the coronavirus. So I'm going to spend more time on the individual organizations, but this is in the context of what we're seeing right now. And the reason we're all home today is because of this. And what I found really super interesting is that this dashboard is a global dashboard, obviously, that everybody's been using. And if you just look at where this is sourced from, there's a lot of very individual sources that they draw out. And that means that as an organization, we also can contribute sometimes to these bigger aggregate views of society and epidemics and crises. It can come from little universities or local news sources or individual organizations that have a particular background in that case. So while we may think about our own organization's health and data, let's also think about the ecosystem we contribute and why that's important. Moving on to what happens when we don't do this. We'll see a lot of this in the news, and if anybody's been watching the US news, you particularly know this from my president, not having data, and I'll just skip through that, but that without data, I think we can't effectively plan, and it can be very disastrous. And this is what we're seeing in the most developed countries right now, which is somewhat ironic. But the US, for example, is not been effectively using data systems and that doesn't have them in place to manage the resources they need for public health during a pandemic. So again, I'm going to talk individually, but I think at the individual level, this is the same. If we don't have data from the programs on the ground, we're not going to know what's actually happening in real time. So that's what we really want to focus on today. Diving in here. Okay, so at an organizational level, we're just talking about the big global scale pandemic, but at an organizational level, what do we mean and why is this important? So I believe that embedding data is important really in three spaces. One is surveillance, one is adaptation, and one is proof. And in surveillance, this is just a fancy word, I think, for monitoring, if anybody's more familiar with monitoring evaluation. But really the sense that without data, we can't be sure that we're not doing harm. That's the part of the Hippocratic Oath. I think no matter what space in health we prescribe to, it's really important that we first do no harm in our programs. So that's a critical piece. And then we can't fix problems we can't see. A lot of times in development, we tend to run programs and evaluate them afterwards. And we'll say, oh, we could have done this better, or, this didn't work after a year or two of an intervention. And we don't really fix that problem because we move on to the next intervention without having changed anything. So that surveillance is really important to have a constant feedback loop. And that feeds in very much to adaptation. So what do we do with data when we get it? And that's very much around staying relevant and responding to the feedback of beneficiaries. All of us many times have been to conferences and seminars where they give us those nice little feedback forms at the end and tell you to rate speakers 0 to 5 and how was the food. I don't know how many organizations have ever used those unless they're just reporting to a funder, but it doesn't usually get brought into the process and the system enough to actually make changes. And so even if it's something as simple as using that, we really want to be better at it. And that helps us innovate. So that helps us change our programs and our approaches more quickly than 2 years after an intervention. And then proof. This is why we constantly connect data, no matter what we do, is to prove to funders or beneficiaries that we are having a difference. And going back to that big picture we talked about a second ago, I really think it's important that we collect data, even if it's from small sample sets, like 1,200 beneficiaries I used to work with, which is teeny tiny. But because that data then can feed into a bigger ecosystem of learning. So, and I'll talk about that more when I talk about my case studies, but even small data sets are valuable to the global conversation around public health. I'm going to fly through because I want to spend more time in the case studies, but again, please stop me at any point that this is confusing. So when I made this title, I didn't just put data collection public health, I put embedding data collection. And what does embedding mean? Like, well, why that word? I tend to be the one that uses it more than anybody else, probably because it's something that I pick on organizations for not doing, and then I try to help them do it better. So the difference between embedding and non-embedding. So separated data collection is around the common things we see, like surveys for survey's sake. We run this intervention program. Maybe it's giving vaccines to a community. And then we survey them after 6 months. So we survey them in a pre-test and a post-test, collect impact data separately from our intervention. That's what I mean by separated. It's usually done maybe on paper, a survey form that we've handed out. And it exists outside of our process and our systems. So if we do vaccine data, this is separate. It is their impact analysis for the vaccines and not part of daily administration of vaccines. Integrated, and this is what I mean by embedded, is different because it's part of the process. So this means there's data collection points on your admission form. If you do a patient intake, that's where you collect your baseline data, not in a separate survey. And I'm going to talk a lot about technology here, and that's because I think it's very hard to use real-time data without technology as a tool. And so I don't think technology is the solution always, but I do think here it's what allows us to use and process data fast enough for it to be useful. So those are the key points of integrated. And then why embedded? You know, why not just those surveys that we're so used to using and seeing everyone else use? A few reasons. There's many more than this, but these are the primary ones I think of. The first one is efficiency. So if it's embedded within the organization's process, it doesn't add additional costs. It just becomes normal for everyone in the organization to use it, instead of adding a different layer or hiring external researchers to come in and do that piece as well. It reduces the burden on those individuals. So if you're working in the field and your job is to give out vaccines, and then somebody's asking you also to become a data administrator and, you know, carry out these surveys, it's an additional burden on your time. It takes more training, it takes more supplies. And so I think we want to reduce how much burden we have so that we can actually deliver our interventions effectively. The real-time review. I've been in many cases all over the world where we collected lots and lots of data, and we garnered many, many learnings from that data, but only very late after the intervention. And therefore, it's great for research papers, it's great for annual reports, but it does very little for the intervention itself. So I think embedding it where we can review it, you know, on a weekly, monthly, whatever cycle is effective, we should do that. And then so that it's prioritized. I worked with an organization once, and they had their field workers delivering the survey forms as well. And obviously, when you're working with vulnerable populations and you're delivering, you know, very needed services in public health, that is your priority. Your priority is not asking questions about, you know, were you satisfied with this delivery, or asking questions on the impact itself that's separated. So if it's embedded, if it's in their intake form, you're not separating it from the intervention itself. You're not taking time away from delivering this service that you are best suited to deliver. So that's what I mean by prioritize. Before I get into some case studies, does anybody jump in, have a clarification on embedded or what we're talking about? If you want to write anything in at some point, I'm happy to look at those as well. So feel free to do that. Okay, so examples from the field, and this is where I want to spend more time, and I would love if anybody has a better example, please jump in with that as well. And just to clarify, these are not all organizations that I have made the intervention. There's ones that I'm familiar with, and I think are great examples. So embedding data, there's a technology called cold trace. And just because we're on I use vaccines as an example, I wanted to show this one. One of the main issues with vaccines, and many of you are familiar with, is the way they're stored. And if they're not kept at temperature, they no longer become potent. And it's basically diagnosing people with, you know, water instead of the vaccine they need. And so there was a lot of humor and error coming up with this. And the old process was that a nurse, as you see in the photo, would go to the cold chain unit and they would check the temperature on a regular basis. So they would be asked in the morning or the evening to go and check the temperature that was on a mercury thermometer sitting on the side of the unit. And they would write it down on a piece of paper on top of that. And that piece of paper would be there. And then if there was any issue, you know, if somebody came and the doctor would check it probably once a month, or whoever was in charge, depending on which country you're in, whoever was in charge of monitoring those different health centers would make their monthly or bi-monthly stopover and check to see what the temperatures looked like. Obviously, this was not really effective because it was too late So they'd end up throwing out massive amounts of vaccines, which is a waste. But they'd also end up not responding to fixes that could have been made very easily. So if the temperature dropped and, it's because the door was open for a little bit too long, they often wouldn't catch things like that. So this wasn't very effective. The solution was actually to put a sensor inside that was that sensor sent information to a center that would then process the data and send alerts back to the hand phone of the person manning that health center. So this nurse is holding her hand phone that would actually send her alert saying the door's been open or the temperature's dropped. And it could also identify why the temperature dropped. And if there was a mechanical fix, it would deploy someone to fix it in the real time. So she didn't have to look at her thing and then go, oh, I think something's wrong. I need to call someone and get them out. The system had already done that for them. And what was great about the so when it shares the data burden, it doesn't ask them to enter more information. It was actually reducing their burden of having to contact people or for this information. So she can just check that the system's working rather than checking the temperature on a regular basis. I think that really changes the usage of data, but also people's response to collecting data. Yep.
Am I the one who lost the voice, or?
I was just about to type that. No, I've said for me too. No sound.
Have you got me?
Yeah.
Yes, Meeghan.
Great. Does anybody, did we miss most of that on cold trace, or does anybody have any questions on cold trace? So I'll just keep talking, but please interrupt me. The reason I'm sharing this case is this is a case of physically embedding data collection. So I'm going to share different types of embedding in the next couple case studies, but this was where you can physically embed it. So if you're in a hospital, this would look different, obviously, because you wouldn't necessarily have a thermometer, hanging in the mouth of every patient. But it's what areas can you physically embed something that collects data that makes it easier. And it might be on the system that the hospital uses. So can you physically embed your own data collection within the hospital's registration system? So that's thinking about like the physical embedment, and then I'll talk about a couple other ones as well. If my audio cuts out, please just shout. Don't be shy about it. So the next case study is the organization I ran. And obviously I'll spend more time on this just because I know it better, not because it's the best. And that was looking at embedding data collection in clinics. So FMCH runs malnutrition prevention clinics. As you see in the photo, it's not a great photo, I apologize, but there was small clinics in multiple locations around Mumbai, all in the slums. And mothers came in when they were pregnant and up to the age of 2 with their toddlers to talk to nurses and nutritionists and doctors, mostly about education, but also about some diagnoses of malnutrition. Originally, when I started working with them, this was all done on paper. So there were paper files at that point for over 3,000 patients. And those files existed in cabinets on site. So if a mother came to a different location, somebody would have to be sent running to the other location to try to find her file alphabetically. Sometimes it was stored by the patient's first name, sometimes their last name. And in India, trying to find anybody's file by a single name was often a challenge. So we had lots of baby Mohammeds and it was very hard to distinguish which one was which. Anyway, we spent more time looking basically for patient records than anything else. And the solution to this was digitizing patient records, so creating an electronic medical record system, or EMR, that didn't make us go through a physical file folder every time, but a digital one. And along that, we created paper IDs. Now, why am I talking about this on the data standpoint? Because this is really about our process. Was the best time to integrate impact measurement data or data collection is when you are making another change in your systems or the tools that you use. Because the team has to go through a training, they have to shift to a new system. And the reason these are hidden figures is this training was not about impact measurement. None of my team had to know they were collecting data that would be used in research or anything else, or an annual report. It was their forms and their process, and it was making life easier on them. So we really don't talk about data collection as the primary purpose of this. It's just hidden within the bigger purpose, which was streamlining efforts. Once things are streamlined, so once you've got everything on there, we did hide in indicators in these forms that we thought would help us measure impact. And to give an example of that, everybody took a height and weight of a child. That was part of our natural process. And then within that, that allowed us to look at their first visits. We have an intake form across their visits. The last time they come in as a 2-year-old. And we were then able to run the data. My internet might have cut out there. I'm still here. They were able to run the data analysis to see what the effect we were having on wasting and stunting statuses were across. So that was all within those forms. None of our doctors or our nurses were actually doing any of that.
You've cut out.
I think all of us working at home is making it harder. Okay, hopefully. So I was going to say was that research questions didn't drive our data collection actually, but the individual process and patient record. And we were able to submit a research paper at the end of this on breastfeeding practices that actually wasn't even on our radar screen going in as what we wanted to do. But it was just because we had enough data embedded within these forms that we were able to pull it out and answer those research hypotheses with that data and aggregate those insights. So it was so hidden that it was really much more about the process and getting that data than it was about the research itself. And I think the real learning for all of us here is that we don't have to create segregated processes for data collection. We really need to think about what are our current processes and how within that can we embed questions, whether it's feedback from the beneficiary or different indicators we already know. In public health, it's very easy to select our indicators. We're lucky that way. In NORA, this might have to do with the education that they're retaining, but instead of having a separate form asking them about the interventions during the intervention, including those questions, including ways to capture that information, that's part of the process itself. I'm hoping I'm still alive, but not. Okay. Third example here. So the first one was really about embedding it physically. The second one was embedding it in our process itself. And then the third one here, I think is actually really closely related to what Nora does and where data collection could kind of go with this. So Last Mile Health, you're probably familiar with. It's an amazing organization globally. But they work on a program with health e-villages. That's health and then e-villages, not healthy with a Y. And they ran something called the Community Health Academy. So they distributed mobile phones to health workers in Liberia. It was basically an app that had a lot of information on it. And in the past, and I've worked a lot in Africa on these kind of programs, a lot of education programs are one way. So whether it's with a beneficiary group, like patients on the ground, or whether it's with community health workers, we train, we educate, we disseminate knowledge to them, and there's no two-way relationship there. So we kind of just, say, here's all the things you need to know. And then we're not able to collect any data because we've, driven all of the communication one way, and we don't really know what the user is doing with that information. So the cool thing about this app was, yes, it had lots of data information going out to the users, which are health workers, but it also enabled them to track every health visit they had with very basic few touch points that they needed to record for their management and to get paid, that also gave touch points on health indicators. For example, if they visited a pregnant mother, then they would check on whether she had her vaccines. And then they'd check on whether she delivered in a hospital when they did a follow-up visit. And they were very basic questions. And this was in response to whatever learnings they had just had. So if they were visiting a pregnant mother, they would watch the video on what the mother needed to know, and then they would respond saying what she had done of that set of criteria that they had given. So that was really interesting because it became a two-way exchange. Now all this data was flowing back into a central data point base, and what I found amazing, because they had so many numbers, they had two. And they were able to identify over 4,300 and they were able to highlight to the national health authorities that these health workers and their aggregated data actually showcased where certain things like malaria and everything were spiking within the country. So I think here the embedding is kind of that two-way always conversation, and Nora is very focused on education, which is incredible, and I think it's important to just make sure that those communication pipelines are coming back as well with the data points we need and not just going one direction. I think simplicity is also really important to the context we work in. So as academic researchers, and I have plenty of years in academia, we tend to overcomplicate things because that's what data and research look like in an academic world. If we're talking about public health interventions, we need to keep them simple. We need to allow workers to deliver that information in the easiest way possible and the fastest time possible. And just to relate that back to the previous case study in FMCH, we had a lot of skepticism when we started arguing to have a technological platform that A, it would cost too much, but B, and I found this very aggravating, that our team of workers who had lower level education than the doctor would not be able to use technology and not be able to enter data. And that was, I think, really wrong in many ways. We found that the field staff actually adapted much faster and were much more adept at entering data than even some of our doctors over time. So I think, yes, be familiar with the context, be familiar if users are illiterate or need different forms of communication materials, but don't underestimate any beneficiary group from being able to collect and input data. I think that's, we're past people being unable to use mobile phones in some form. So that's all I wanted to say on that. Anybody have any questions about these three case studies?
The last mile health?
Yep.
You said it was a two-way communication, and these were frequent visits done by the health worker to be able to capture the previous health education?
Yes.
Okay.
So yeah, they would watch something actually, so some of them were focused on different areas like maternal health or malaria prevention, and they would go into a household and they would watch the videos for that particular case before they went in. So like if they were supposed to deliver malaria intervention information, they would watch the video. They also had videos that they would show directly to the beneficiary. So, why mosquito nets are important. They might pull out their mobile phone and show a video to the beneficiary saying why it was important. And at the end of that, as a summary of that, which was part of the process, they would enter, does the family have a mosquito net? Yes or no. Has anyone had malaria in the last 3 months? Yes or no. So basic things like that. But they weren't filling out massive surveys on the whole household every time. And I think if you imagine trying to do that on paper and how effective that would be from 2.3 million visits, we have how much paper? Sorry, go ahead.
Yeah, thanks. That was very useful.
Okay. Great. So in the interest of time, I'll just get to the next session and then we can have a bit of an open discussion and questions. So how do we do this? When I go in and advise an organization, there's very basic things that I advise on how to get this going. And though it may be more complex depending on what we're working on, I think it is very basic in nature. Embedding data collection is not as complicated as creating separate data systems. It just requires a little bit more foresight. And as part of that, it's really to integrate from the onset. It is easier to incorporate, like I said before, the data collection into new processes or systems that you're implementing, rather than incorporate them after you've already introduced the process. Meaning, if you already have intake forms, it's going to be harder to incorporate just the data collection piece on those intake forms than a piece with the data collection within it. Because people are going to need retraining across the board, and it's part of their day-to-day, and it's not separated from their day-to-day work. So I really think integrating it from the beginning is helpful. That doesn't mean if you're already doing work, which we all are, that you can't still embed data collection. It just means think about it while you're doing a broader system overhaul or as part of your change in your organization. Embedded in the retraining process for something bigger than just data collection. And then I think it will be taken easier and more seriously, like the spoonful of sugar theory for data collection. Investing in technology. So all three of the examples I showed you were tech-based. There are some that are not, but I would argue it's really hard to have real-time data collection without technology. Just because anything that requires paper or even audio translations takes us a really long time. And we're just often too late, or it becomes the least important part of our day, going through a million different paper forms and uploading those. So technology is really critical here, and it can make our lives a lot easier. It's used really well. And then adapt to context. So the three examples I showed were all in very different parts of the world. And I think we have to be wary when we're talking about data collection that is context specific. So if you're working in hospitals in India, that's going to look very different than hospitals in the US or in Malaysia, where I used to work. And I think it just, this goes without saying, we all know this, but just be very aware that, technology tools will only work in certain scenarios where they have been adapted for. So a lot of what we use in rural Africa is SMS-based technology instead of anything that requires a web connection, because you'll go offline. In India, also, our iPads that we use in clinics, we had mobile Wi-Fi routers, but we also enabled them with offline technology so that the iPad could use offline and then brought back to HQ and that data then uploaded. So you think about those contexts as you start thinking about the technology and the data itself. Collaboration, and this going back to the big picture today and thinking about where we are with the global pandemic. I think that a lot of times we only see our data as something that we need for our donors. And I think especially in public health, it's not something that we need as a sector, it's something we need as a community and as a society to share this more broadly. For those of you who know the Goalkeepers report from the Gates Foundation, that is a lot of data drawn from programs all over the world, but it gives us a sense of where we're going as a whole on really key indicators. And no matter how small an organization, whether you're working with 200 people or 2 million, I think you can contribute to that information. And sometimes even the small organizations have more in-depth knowledge of what they're doing because they have a deeper intervention with those individuals than somebody who's working with 2 million. So be willing to share and be willing to think of yourself as important in a larger ecosystem, and don't undervalue the data you're collecting. So that's what I wanted to do. I really wanted to spend more time discussing in person, and we're going to try to do this online if we can. But I wanted, just to hear anybody's questions or thoughts. I'm totally confused, like more case studies. Have I been offline the whole time?
Can I just quickly ask that the Gates Foundation, the document or the collection, kind of like the aggregate of everything, what was that called?
It's called Goalkeepers.
Goalkeepers, thank you.
Goal, like the soccer term, football term, GOAL, Goalkeepers. And if you look, what's really fascinating about the site, they also have a breakdown of the SDGs and the targets. So they correlate all that data to the SDG targets. It's a great resource.
Thanks, that's great.
And I'll share the slides too, so if there's any small links you want to pull from there, please do.
Oh, that would be great.
Any discussion around kind of, how Nora does this now and how you think about it, whether from, the deliverers perspective, those of you who are in the field and delivering programs, or from the perspective of those of you doing research. I know, Seema, you spend a lot of time on this. So happy for this to be discussion also about internal work.
I have a couple of questions.
Great.
One is just wondering, aggregation of data, what you talked about that report. I was just wondering, with the different organizations collecting the data very differently, with different questions, different tools that they use, how easy or difficult is it to do this aggregation? And as a ancillary to that question, kind of how important is it for us to adhere to standard set of questions so that we can bank on other data sources that are there? Any thoughts on this, like more in specific to kind of our context?
Yeah, those are both great questions. I think on the first one on aggregating, in public health, I find it a bit easier for us to find common indicators. So if you go to Goalkeepers, for example, there are certain things like maternal mortality or birth weights or malnutrition that have common sets of indicators within that. And I think we should align not everything we do. Obviously, like our internal process and feedback will be different, but at least the global kind of view of those impact indicators should be the same. And you may have many, right? Like you're focusing on maternal mortality. You might also be focusing on cardiovascular, these different components of that, but there are aggregated indicators. And that's maybe a good place to go first, is both the SDG targets, which are a little bit more global and broad, but also the Goalkeepers kind of public health targets. So I think we should include those because A, it adds a lot of proof and validity to what we do, but B, it also allows us to contribute to that aggregate picture. On your second point, it was, remind me what the second point was.
I was saying, yeah, I think you answered that already. I was saying, should we include the standard tools and standard questions in our tools?
Yes, that's an interesting. So these are standard indicators, meaning these are kind of the components that you're collecting data on, but the tools can be very different. So there aren't any standard tools per se. You know, even a hospital intake form in different countries or for different interventions looks different. And so I think the tools we can use can be very context specific, organization specific, but what we're trying to gain from those tools will be more global. I don't know if that's a better way of framing it.
Yeah. Thanks.
Does that answer your question, Seema? Sorry.
Yes. No, definitely it does.
Hi,
Meeghan,
is
this
Varun
is Shahid. Oh,
Varun, do you want to
Varun,
go
why
first?
don't you go on ahead? I,
Yeah, I'll be less charitable. I started first. Yeah, so I'll explain a little bit of what we do currently. I've had a little doubt in how to view this one particular process. So when we conduct sessions to say family caregivers in hospitals, these are like educational sessions on focused on health education or MCH or oncology or one of these one of many subject areas. So these are like groups of 25 to 30 patients and their family caregivers in a classroom kind of a setting inside a hospital ward. So we have a longer term evaluation process, which is not quite embedded real time the way you described it, where we um, call up say mothers a month or so after their sessions are over, after they have attended a session, and then ask them a set of questions which speak about their experience in the hospital, what they've learned, to understand if their knowledge is any better now after a month, whether they are actually practicing any of those things which they learned in the classroom, whether their behavior has changed, and so on. We also try to make home visits a while after the session is over to understand if they really are doing it, if it is built into their culture, their family culture as yet, and so on. While the more real-time process is immediately after the session, we quickly check with the kind of like a pre-post, like before the session, what was the knowledge, and after the session, what is the knowledge now looking like. We can't really gauge behavior, but at least the knowledge we try to understand. But one like I understand intuitively, it sounds like a good way to quickly check the pulse of what is happening. But I also wonder what since it's done so instantaneously, how much to what to make of those answers. Like if they're really positive as well, then what do you really make out of that? Because it's information which was said just a while back, so you can quickly recall that anyway. Most people would be able to if they were listening in the classroom. So what would you make of those real-time indicators, as opposed to if you're doing it after a month, then you really understand, hey, if they've retained it for a month, if they're really practicing these, and you can ask more questions because, and you can plug in more questions and understand really if what they're saying is true, whereas a pre-post is slightly difficult to do that. I don't know if that makes
No,
sense.
that makes so much sense, and that's a great point in the question as well. Um, I'm sorry, when I meant real time, and I didn't clarify this super well, the data as it was coming in could be reviewed and aggregated in real time. So when you're doing those home visits, it's not that the home visit's not real time because it wasn't during the education session. It's that the data collected at the home visit is being kind of brought back and reviewed in real time. So it's not sitting on a paper form and then 6 weeks later an intern's entering it, and then 6 months later we're looking at the Excel sheet the intern did 6 months ago and saying this is what happened. It's more that the data as you're collecting it is then in a usable form or being pulled from. So that's what I meant by real time. You're absolutely right on the education point. So if you are asking people, right after they've heard, point XYZ, they're obviously going to remember point XYZ better than they do 6 months down the line with a phone call. So I still think that's valuable. I think what we're talking about here, though, is more, are you doing those phone calls just for the sake of data collection? Or could that be more engaged in the process? And Seema and I have discussed this a few times, but those phone calls are actually part of the education as well, right? So when you're calling and asking these questions, that's actually a tool for providing a 6-month follow-up education course with individual mothers, because when you're asking them these questions, you're also reminding them of what they should be, you know, what they should have retained, and can it be used that way? So it's almost using it as a programmatic tool instead of using it as just a data collection tool. And the same thing with the home visits. If you're just going home to ask them your survey questions, I would just argue that that's maybe not the best use of resources. You know, how could those home visits, as I'm sure you do already, but those home visits be more about sharing the education again and being the touch point? And what data can you collect during the first interaction? So during the 25 or 30 sitting there, that is easy to collect during that session as a baseline. When I've run educational sessions in big groups, I often do things like have them raise their hand, you know, and count numbers that way instead of filling out survey forms, and then take that down. Or if there's some sort of textual that they can use, we include that as a starting point for them to create their profile, and that textual and that profile serves as their baseline for us moving forward as part of that session. So yeah, I think you're exactly right on every point you've made, but it's really just thinking about not separating that collection from what you're actually trying to do. So if it's education, you know, can you ask those questions during the conversation?
Megan, can you be closer to the mic, please?
Is that better? Yeah. No, why? Anyway, I think I need a new headset. So I think the point is just how do we embed that further, and how do we make those sessions more useful, not just to collect data if we're calling. And Seema and I, we've had these conversations, and I think you guys are already on the right track. But that's what I would say. Varun, did I answer your question?
Yeah, I'll ponder over what you said a little bit more.
Okay,
Thanks.
feel free to ask follow-up. Shahid, were you jumping in after that?
Yep. Hey, this is Shahid. Sorry, I was muted. And overall, my computer is giving me a little bit of trouble today. Yeah, I think Varun actually covered part of the question, but just wanted to kind of, and you know our model and system fairly well. And so one of the things that is the case for us, both on the monitoring and the evaluation front, is, you know, since we are kind of a health system strengthening organization, we're not providing kind of direct service or delivery. A lot of what we do is embed systems and embed processes and kind of overall within what is the infrastructure in place by the government. And currently, unfortunately, there's, you know, very little kind of data that's being collected, that's digitized immediately, that's available for us to, you know, hop on and kind of add, you know, let's say a field to, or you know, something that's useful for us. And also in terms of looking at, let's say, health outcomes and indicators that are relevant for us, these are typically things that are currently, again, not being collected by the government. So we typically, you know, in setting up these programs, have had to, on the evaluation front, of course, go in and design our own studies, and we do that from time to time to collect information that's relevant for us purely. And you mentioned some of these reasons, but you know, usually this is from proving out impact and proving out outcomes, so that we can continue to have support for the program from both kind of funders and governments. So that's something that's challenging. Is one, we have to go in and every time we want to approve something, go and collect our own data, because that data is currently not being collected, and not being collected in the way and aggregated in the way that's useful for us. and two, even on the day-to-day monitoring, you know, these are processes that would be out of scope from, you know, what is the current standard of data collection with the partners that we work with. So I guess the question is, you know, hopefully, you know, one, you know, there are governments and there are systems coming into place which are you know, being which we could eventually, I think, you know, tag on to as they get up and running. And you know, there are HMI systems, and not all of them are equal, and hopefully one day, you know, we can you know, we can be a you know, let's say even a radio button or a tick box in one of these things. But until that point where we can truly leverage you know, systems that are already in place, how do you recommend, and maybe you can just talk through yeah, like whatever is kind of top of mind, how do you recommend an organization like ours who who needs to, you know, kind of collect things to continue to understand our specific impact and our specific you know, quality of service delivery, but we also are very, you know, are very aware that we are creating a system outside of, you know, outside of what is ideal, which is embedding something into the process, you know, of care delivery within these facilities. And inherently what we're doing is adding some sort of workload for someone, whether it's, you know, a nurse in a facility or our own staff, and creating a data stream that is outside of, you know, one that is already being captured. I mean, that is a challenge and kind of an inherent part of our work right now. And you know, part of it, you know, the challenge is also kind of feeling feeling that, you know, we're adding to the burden of the system in you know, introducing data collection practices, and you know, we really try to be thoughtful about that, and have the nurses not, you know, not do anything extra, you know, it's just in the name of data collection, but always try to be really thoughtful through, you know, every single part of, you know, what we ask them to do. So it's a conundrum, and obviously there's no like easy answer, but would love for you to, you know, shed some of your insight onto kind of this phase that we're in, where currently, yeah, we can't rely on systems, which would be the ideal that would already be in place.
No, great, and you've summarized that so well. I think that there's several things in there. The first one being that there is no easy answer, silver bullet that I can give right now, or that any of us have to doing that better. And then I also want to say that I work with a lot of organizations, and Nora really goes above and beyond on the data collection front right now. So what you're doing, I would say, is, you know, way beyond, you know, the average as far as thinking about data collection and pursuing data collection, using data for impact. So everyone in the organization should feel very proud of that and the work you've done already. And so I think what we're talking about today is like, yes, you're already doing amazing things, and then how could this be streamlined a little bit better? And that's what you're speaking to now with this question. And the other thing you brought up, which is really important that I didn't discuss during the earlier slides, was the separation, kind of this monitoring data and collecting that, and then the evaluation data. And I think this is particularly pertinent to your case with Nora because of the way you're working with healthcare professionals, and then they're actually, you know, they're touching the beneficiary directly. And I think when we're talking here, monitoring is where we can embed further, and evaluation still may be a piece that exists outside or separate because of that context. And so let me talk a little more about that. Monitoring and getting that kind of feedback loop on, are we doing what we say we're doing? How well is it going? Could we adapt? Could we change? Has to come from the people who are delivering the service directly to the beneficiaries. So those healthcare workers, it has to be kind of incorporated into what they're doing. Like you said, that can't be in the current Indian system through the government. So the government's not going to be helpful in providing that currently. And the way I've seen this done, and feel free to push back and say this isn't really relevant, but those individuals have to get trained, right, to deliver this information, and they have to be given some sort of resources. Like in that case that I showed you from Last Mile Health, information is pushed out to them to then share. And the key is, how can we enable them with a tool? So is it a Nora Health, app or whatever tool it is? How can we give them a tool where it's very easy for them to then input their feedback, but also collect data points from the sessions they're delivering, that is easier to use? So I know Nora already does this, but how can we make it easier for them to use and show them? We're very competitive creatures, humans. And so how can we show them how well they're doing? How can we show them that the data that they're contributing, that they're giving back, is useful? And this can be simple, like it's just data visualization usually, like look how many people you've trained, look at this. I think giving them that real-time response to what they're entering is really important. So a lot of times we'll ask people to submit reports and they never see the outcome of those reports, or they never see the aggregated view of that report. They just feel like, oh, I went into the Excel sheet, I filled out rows, and then maybe a year later we get like some report on what happened. But individually, they have no ownership then of the data they enter. So on that monitoring side, I would say give them a tool where they're, seeing that feedback loop. I don't want to say app, because apps are sometimes the worst idea, but something like that. I mean, we should brainstorm that more, where they can see what happens to that data and see their individualized data. On the evaluation side, I think it's going to be hard right now to get around doing it the way you're doing it, which is with the site visits and the home visits or the phone calls, or evaluation research pieces through third parties. I think those are above and beyond what normal organizations would do, but I think that is also how you contribute to the ecosystem, because you're doing extensive research in that space. So I wouldn't worry so much about embedding that right now. Having that in the back of the mind is good, but the monitoring piece, I think, is where we could really talk more about embedding. Does that make sense?
Yeah, it definitely does. Maybe this point that you just brought up about, actually, I will save my question and let others ask. But thank you so much, Meeghan. And I can take my other question offline with you at some point.
Okay. Unless anybody else doesn't have a burning question. Or comment, or a great example that they want to share as well. You're all experts here.
Would love to also open it up to the non-Nora folks. If you might have any comments, thoughts, and would love to hear also about kind of your own organizations and own systems, because that's one of the things that I think is really great about this, is that we can share with one another.
Yeah, hi, this is Vijay from Stir Education. Yeah, I guess thanks, Meeghan, for sharing this. I think it's clear that tech is one way to, that we all need to figure out how to use, to basically need to crack it, because I do understand that we do use tech, but what's the best way to use it? Where do we really how do we leverage it? Is something that we're still debating and discussing in our organization. I was just curious to know, when you said in one of the slides about not answering a research question, but letting the data that you collect leading to a conclusion. I was just curious about how that works.
Yeah, I want to make it sound really intelligent, like we had some sort of great foresight there, but it was actually more accidental. So we had adapted forms, medical forms, to what we were doing. So basic medical forms on different things we were tracking for the clinics. And then we ran these education programs outside the clinics, and we were tracking basic attendance, to be honest. So it was really just keeping track, monitoring as you would for any organization. And what we did, the research piece that came out of that, which was not the question you were asking at the time, was when we looked at the correlation between our attendance tracking for those beneficiaries as well as the medical data points we had for them, we were able to draw conclusions. And I wish there was some great wisdom in what we were doing, but the point was that if we had that data, like if we were collecting enough of that basic monitoring data, we could actually answer evaluation questions without having foreseen that. I don't know if that makes sense.
Right. Okay. So is this a scenario where you had some sort of big data that was available in the system, or what is generically available, and then you sort of use that to build your correlation?
Yeah, we're nowhere near big data. I think when I was there, we had reached about 6,000 beneficiaries. So I wouldn't call that big data.
Right.
But we had enough data points to start drawing some conclusions, yes. And I've seen this work in other scenarios, schools, for example. So looking at, you know, retention rates versus, you know, which curriculum they were using. You know, there's different correlations we can make and back up from basic monitoring of what we're doing.
All right, thanks.
And do you want to share a little bit about the work you guys are doing?
Maybe not right now. Maybe we can finish with questions and then maybe later. Yeah. Thanks.
Great.
Yeah.
We have about 9 more minutes, so please, anybody who wants to jump in, don't be shy, even if it's just to make a comment or an insight that you have from your own field. Can I just ask that if anybody's from a different organization, is there any way that you're doing this already? You know, I've talked from my experience, and we know a bit about Nora, and everybody from Nora knows Nora. But then anybody from a different organization that has been doing data collection in some form that they think might be an interesting case study.
Sorry, has anybody used, Meeghan, you or anybody else here, used WhatsApp for a two-way data collection? Like, get feedback on WhatsApp and use that for data?
Anybody else?
No, no, I haven't used. I mean, at least we haven't, and also not in the previous organization I was. I have no experience with WhatsApp for that.
Thanks.
Seema, I'll jump in, but anybody else who has better examples, please come in. I've used it mainly in feedback cases. So having people who are working in the field send over feedback that we could then aggregate, but more on the qualitative side, less on the quantitative side. And more recently, working with an organization that works with the deaf and hard of hearing. And so a lot of the actual data collection from the community itself is done on WhatsApp so that they can share video sign language. Because obviously writing in different languages is difficult. A lot of the users are illiterate. So that's another case of using it. It's, for me, the challenge with WhatsApp right now is the analysis. So aggregating and analyzing whatever you get tends to be just as difficult if you're using anything else, like a paper form or anything else. You still have to kind of pull all of that together and sort it through. So I haven't come up with a good solution to that, to be honest, but I have used it just to get that feedback